We are live in 3, 2, 1. Please start, ma'am. We are live.
Very good evening, one and all. Very good evening to senior professors and fellow doctors. We welcome you all to yet another session of Cardio PG Masterclass. Here we intend to and endeavor to exchange ideas, facilitate learning, and empower young cardiologists. So we have with us Professor Dr. Ajay Mahajan sir and Professor Dr. Kamal Sharma sir, who are the course director of this program. The topic, the presentation today would be on peripheral vascular disease. And these are our senior faculties who will be guiding us throughout the sessions. And here I now have the honor and privilege of introducing our esteemed faculties for the day. We have with us Professor Dr. Ajay Mahajan sir, who is Senior Consultant Interventional Cardiologist, HOD of KEM Mumbai. We have with us Dr. Kamal Sharma sir, who is Senior Interventional Cardiologist from Sal Hospital and UN Mehta Institute of Cardiology, Ahmedabad. We have Professor Dr. Manutosh Panja, who is Director of Interventional Cardiologist at Bellevue Clinic, Senior Consultant Cardiologist, AMRI, and BM Birla Heart and Research Institute, Kolkata. Last but not the least, we have Dr. Tanuj Bhatia, who is Associate Professor and Cath Lab Director at Department of Cardiology, SGRR Medical College and SMI Hospital, Dehradun. And we have Dr. Damini, who is the PG resident, and we wish her all the very best. And without further ado, I hand over the session to Dr. Kamal Sharma, sir. Thank you.
Hi, good evening, everyone. Welcome to this session, and this is the fourth in the series. We have had three previously very engrossing sessions, more than 500 plus attendees all throughout, and now we are going to discuss a case of peripheral vascular disease with focus on aortoarthritis. So I am on behalf of all the faculties that we have joined today, Dr. Panja, Dr. Bhatia, and our senior faculty, Dr. Ajay Mahajan, I invite you all for this session on case presentation on peripheral vascular disease, especially with focus on aortoarthritis. We all know Dr. Panja has been an authority in aortoarthritis with a lot of publications in the same, including his book that I myself read, and Dr. Panja was my examiner when I appeared for DNB after my DM at our in our hospital, and he was the examiner. Panja, pleasure to have you and share the same platform. Dr. Bhatia is the faculty for Dr. Damini's Institute. So looking forward to have this. So Dr. Damini, over to you. You can start your case presentation.
Thank you. Just a minute, I will share my screen. Are the slides visible? So shall I start? Shall I start the presentation?
Yes.
Okay.
Yes, please.
Good evening, everyone. It's an honor to be presenting the case in front of all you esteemed panel. So we'll be discussing a case of peripheral vascular disease. We had a patient, 62-year-old ex-serviceman, who is chronic smoker and alcoholic, post PTCA to LAD and RCA in year 2021, and was diagnosed case of peripheral arterial disease since then. He came to SMIH emergency with chief complaints of pain in left leg for 5 months and numbness over the right thigh for 5 months. The pain in left leg was in the calf region, insidious in onset, non-progressive, cramping in nature, precipitated on walking about 100 meters, which compelled the patient to take rest. The pain subsided in taking rest within 5 minutes. The pain relieved on holding the dorsum of foot dorsiflexed and holding the affected limb. It also relieved on suspending the legs over the edge of bed. It got aggravated on going uphill, then going downhill. It was associated with loss of hair over the left calf, as the patient complained. It was associated with cold temperature on both his calf, more in the left lower limb than the right limb. It was not associated with any fixed skin staining or gangrenous changes or changes in the skin texture. Void grading, according to the history, was grade 3, claudication distance 100 meter, and Rutherford grade 3. The numbness that the patient complained over the right thigh, which was for the period of 5 months, was insidious in onset, non-progressive. It was precipitated on walking a certain distance and was relieved by taking rest. It was not associated with any rest pain. The patient also complained of exercise intolerance since the same period of time. It was exertional dyspnea of grade 2, NYHA grade 2. It was not associated with orthopnea or PND. Patient was a chronic smoker and alcoholic since past 40 years, and he has mixed diet and no bowel or bladder difficulties. Past medical and surgical history. In the year 2021, November, patient had an episode of acute coronary syndrome and CAG was done. Uh, and the patient underwent PTCA to LAD on 27th of November and the PTCA to RCA on 30th of November. During the same time, the patient also complained of pain in bilateral lower limbs, for which he underwent bilateral arterial and venous color Doppler, in which bilateral common iliac artery origin stenosis was observed. In December, the patient underwent a scheduled PTA to right common iliac and left common iliac in view of complete blockage of right common iliac and 60% stenosis in left common iliac seen in peripheral angiogram. On 10th of January of 2022, a CT angiography of ascending aorta and bilateral upper limb was done in view of the patient complaints of left upper limb pain, which revealed a non-enhancing hypodense thrombus in proximal part of left subclavian artery of length 2.8 centimeter and diameter of proximal thrombus segment 11 to 12 millimeter. In mid part 7.3 millimeter and diameter of subclavian, the thrombus 5.4 millimeter with complete occlusion. So DSA and PTA to left subclavian was done in January 2022. A CTA done in 2022 was also revealed left common iliac artery and left saphenofemoral artery occlusion, femoral and left CFA to SFA bypass and left SFA embolectomy was done on 23rd of 2022. Post procedure, the period was uneventful. Again, a CTA was done in an outside hospital for persistent lower limb pain, and it revealed left common iliac artery and left saphenofemoral artery occlusion. A femoral and left CFA SFA bypass was done. In the year 2023, the patient presented with chief complaints of pain in the left leg and numbness and paresthesia over the right thigh, for which CTA abdominal aorta and lower limb vessels was done. The patient also underwent a CTA of upper limb, which didn't really reveal any abnormality at that time.
So we can stop here for a while. We can, on the basis of history alone, what do you think is the pathophysiology that's happening, that's progressing?
Sir, as the patient is a smoker and also he has had a coronary. Just a second. As the patient is a smoker and he has already had a coronary event, he is predisposed to arterial diseases. So most likely he's suffering from a peripheral arterial disease.
If you do not have the past history, what makes you think this is a vascular claudication and not neurogenic claudication?
So as per the history, the patient can walk for a certain distance and then experiences pain, and it is not just just with the start of a movement or with any movement. He has a time period of moving and then gets the pain.
What other features differentiate neurogenic from vascular claudication?
So neurogenic pain usually is
radicular pains, root pains,
yes, sir.
skin changes,
Yes,
gangrenous
sir.
changes,
These are
autonomic
seen in
disabilities,
all
proximal
these
versus
changes
distal.
For these
If the
cases,
patient diabetes
no, sir, the patient is non-diabetic.
or
Why
country
is that
prevalence
question
of the
important?
yeah.
So
Or,
diabetes itself is predisposition to atherosclerosis.
so in our country, when there is a prevascular disease, more than 80% cases associated with diabetes. So therefore, 20% case without diabetes may happen. So which is happening in your case?
Sorry, sir.
So diabetes, I mean, when you have a diabetic atherosclerotic PVD, what are
Yes.
the differences that you should anticipate compared to a non-diabetic patient? Diagnosis, prognosis, and treatment. How would the three differ if you have a diabetic atherosclerotic PVD versus a non-diabetic atherosclerotic PVD?
Sir, in a diabetic patient, the control of blood sugar itself becomes the primary the
So
treatment.
how is diabetic foot different from gangrenous atherosclerotic foot in a diabetic?
In the diabetic foot, the occlusion of artery is basically due to
You have to
uh,
know that pathology of the peripheral vascular disease as well as coronary artery disease, you have to
yes,
know that it is thrombus containing lesion, number one, angiographically. Second, it is ulcerated lesion. And third is long lesion, multiple lesions. Okay,
yes.
three characteristics is very important because plasminogen activator pi is very high in cases of diabetes. That is the reason.
Okay, sir. Okay, sir.
So can this be anything other than atherosclerotic? Because in the light of history that you get coronary artery disease, would it always mean atherosclerotic? Or in the other words, can you give me a cause of non-atherosclerotic disorder where you have coronary as well as peripheral vascular disease involvement?
Vasculitis, sir, we can have
Which
such.
vasculitis has coronary involvement?
Sir, Takayasu can have coronary involvement.
What percentage coronary? Is it common, uncommon, rare?
Subclavian arteries we can get occlusion in subclavian, but
No, subclavian is a mandatory criteria. What are the criteria of aortoarteritis?
sir, it is
What is the name of
rare
that
in
criteria?
You know, in our series 750 cases, 10% cases associated with coronary involvement. And we have classified the classes of the different type of class 1, class 2, class 3, class 4. So I published in JAC, we qualified the coronary is class 4. So because of 10% cases, it is involved, fairly common.
That is Dr. Panja's classification, Panja classification of aortoarteritis, where you have 4 defined as coronary involvement, 5 defined as pulmonary arterial involvement. That's how the definition was. And again, Ishikawa criteria is the original criteria, Damini, as there's been
yes.
defined for defining aortoarteritis. And there is another modification. One more Indian person has contributed to it, and that is called which criteria? Sharma et al.'s criteria, not me.
Yes.
That's not me, Sharma. There is another Sharma. So it's their criteria where they have included definition of involvement of coronary. So that's how the two definitions of Dr. Panja and Dr. Sharma differ. Dr. Panja subcategorizes pulmonary involvement as the fifth class, while Dr. Sharma's classification did not categorize that. So that's the difference. Correct me, Dr. Panja, if I'm wrong. If that is
Yes,
how
you are
it is.
correct. Pulmonary involvement in our series 36% of cases, they fairly common. So pulmonary is a medium size to large pulmonary is involved, not this too much small peripheral artery. Large and medium size of pulmonary involvement. And these, because of pulmonary involvement, sometimes the pulmonary arteritis. Why it is? Because of pulmonary arteritis. A patient presented with low-grade fever and the hemoptysis. So therefore, that is pulmonary arteritis is the disease of the activity of disease of the Takayasu arteritis. Some cases when the pulmonary involvement, patient may present with pulmonary arterial hypertension. Therefore, pulmonary hypertension, idiopathic pulmonary hypertension is a consequence of aortic arteritis because of pulmonary arteritis.
So coronaries you would categorize as what? Small vessel, medium vessel, large vessel,
This is the
arthritis.
medium-sized vessels were.
Yeah.
Because classification again, coronary class 4 classes. When the ostium and limb mechanism disease involved, coronary involved, there is class 1. Class 2, when there is a particular involvement of the sarc or LED associated with the ostium of the artery. Third category were classified by the aneurysm of the coronary artery, all as well. Coronary artery either is mid part of the RCA or sarc or LED. So these are the three classifications we have mentioned. And in between, there is a combination lesion class 4. So this is our classification. And also Park, John Park found the Seoul, they also, they are classification same.
So Dr. Damini, how is the pathophysiology of atherosclerosis versus aortoarthritis in terms of whether both of them are panarthritis or some of them are focal arthritis or there is no arthritis at all in atherosclerosis? Where is the inflammation in atherosclerosis and where is the inflammation in aortoarthritis?
Sir, in
Good
atherosclerosis,
question.
in atherosclerosis, the inflammation starts from intima and then the plaque progresses. And in aortoarthritis, it can be panarthritis also.
It is panarthritis. That's why
Yes.
you get
Yeah.
more of stenotic lesions. The disc beaded up, the appearances that you can get. You have some like aneurysms, some. So it's panarthritis versus predominantly intimal inflammation or erosions and plaque inflammations that you get.
Another
Right. So what
important,
about? Yes, Dr. Pan.
yes, another important things to be remind in cases of the, some cases, that is arteritis, that means coronary arteritis or peripheral arteritis, along with the some atherosclerosis. You know, some collagen disease, rheumatoid arthritis, you see, number one. Second, Takayasu arthritis, Wegener syndrome. These are the associated premature atherosclerosis because of inflammation. So maybe associated with atherosclerosis as well. Okay.
Yes.
Right. So for the atherosclerotic, you mentioned certain grades. Boyd's is one, like you remember NYHA for cardiovascular disorder. You mentioned Boyd's here. You mentioned Fontaine's. You mentioned Rutherford. So can you tell me which of them is used for acute, which of them is used for chronic, which of them is for symptoms, which is according to the severity, and one classification that's angiographic. Which one is the angiographic classification? TA, transatlantic. You heard of that?
Yes.
Yes.
So what's
You have to know
transatlantic?
it
So
properly, yeah.
the guys across the Atlantic, they sit and create an association and define a TASC classification, Transatlantic Society, right? So that's the other angiographic classifications which defines the lesion. So you should at least, it's a long one. If you remember, well and good, but you should know the name because that's what you're going to come across when you have to take a call, whether you're going to send the patient for surgery versus you will do endovascular, which patients would do well according to which TASC classification, what grade, how long is the lesion, what's their severity, whether it's above knee, below knee, what category. So that classification is important for that point of view. So acute versus chronic, which one of them can be used and which cannot be used, or all are interchangeably used?
Sir, Rutherford can be used in chronic limb ischemias, and Fontaine and Boyd's we can use in acute.
No, so Boyd's is symptoms. It's like NYHA
Yes.
class. Boyd's is interchangeable for both. You can, it's like categorizing the claudication history. How severe is the claudication? That's what Boyd's does. Boyd is interchangeable and can be used for limb claudication as a symptom severity. Fontaine and Rutherford are used for acute versus chronic, as you mentioned. And then Rutherford, of course, you can use interchangeably. And Sky, task classification is angiographic one. Okay. Does the age matter? Suppose this was a child. How would that diagnosis differ?
Sir, in children we would think more of vasculitis as it occurs in mostly in young age, but as the patient is elderly and has a history, of smoking. So we are
Right.
thinking more towards.
So you covered almost pretty much everything, but I think you should also look at the history of acute phase. So what are those histories that you should be asking to rule out an acute phase of the illness in case it's an arthritis? It may be osteoarthritis or may not be an osteoarthritis, but so what can you ask in history and what you can look in examination to rule out an acute arthritis in a case a patient you are dealing with is an of non-specific or even any other arthritis for that matter?
So in arthritis, we can get constitutional symptoms like joint pains, fever, and other fatigue. And also we can get signs like Raynaud phenomena or so
What is carotidynia?
carotid. Yes, sir. The patient will feel pain on the subclavian and carotid region.
Palpation. So patient can sometimes present with jaw claudication like symptoms or pain on deglutition also, or patient can have symptoms like throbbing headache, tenderness over the arteries. Uh, those are the other symptoms, pain over the arteries that the patient can sometimes present, especially in the neck vessels. That's where you should be probably be asking for. And also, of course, history of loss of appetite, constitutional symptoms like fever, low grade, malaise, fatigue, joint pain, etc., which you mentioned. Right. Which are the large vessel arthritis that you know of?
Sir, the giant cell arthritis and Takayasu disease.
So where would you what is the temporal arthritis like? Which kind of arteries are involved and which is the age group classically involved?
So temporal arteries are medium-sized arthritis, and age group of 40 to 50 middle-aged people are involved.
No, temporals are usually elderly. So when a 70-year-old guy comes to you with jaw pain or headaches and bilateral or unilateral visual blurring and more importantly jaw claudication with an ESR of 100, that's the spot diagnosis of temporal arthritis. And then you palpate the temporal arteries, they are palpable and tender. That's how you will make out usually a male patient. So usually the arthritis are female dominant, right? Except
Yes.
temporal,
Temporal
which
arthritis.
is predominantly a male arthritis, right?
Yes.
Dr. Tanuj, any other question? Dr. Panja?
What is the age cutoff that you classically think of temporal arthritis? And just echoing the question of Dr. Kamal Sharma, sir.
So 60 to 65, like it is most commonly seen in
50, anything more than 50, you should be suspicious.
Yes. Another important point, SLE should be keep in mind because the SLE also responsible for premature atherosclerosis. You see, I told you at the beginning, rheumatoid arthritis, Weisner syndrome, Takayasu arthritis, and SLE also premature atherosclerosis may be features of the peripheral vascular disease as well as the coronary disease may be happen. That is also keep in mind.
Okay, sir.
So does rheumatoid arthritis also increase the risk of CAD or events?
Yes.
Yes.
Rheumatoid,
Damini?
Yes, sir.
So any scoring systems that you know which takes that as a risk factor? Can you tell me some prognostic risk scoring systems, Dr. Damini? Where the PVD is considered as a, or even rheumatoid arthritis is considered as a prognostic predictor for 10-year survival risk calculator. Have you heard of QRisk? QRisk. So QRisk includes migraines, rheumatoid arthritis, QRisk 3. And it also considers ethnicity, including, so Dr. Bhatia has already been to UK, so he knows that. NHS has got a data set where it tells you Indians, Pakistanis, Bangladeshis. That's the only one which can differentiate between the three ethnicities, though we are ethnically one and same. But they have, from the NHS data set, looked at the population base who are living in UK and found out as to how we are at more risk than Pakistanis, but Bangladeshis are at more risk than Indians. But then overall, of course, it's just a 1:1.1 versus 1.9. That's how they quantify. But it includes two important predictors. One is RA, another is migraine. Migraine for stroke and RA for coronary artery. So autoimmune disorders are known
SLE
to
also.
SLE also, which Dr. Panja had asked.
SLE.
Correct. SLE also. So SLE and RA, both. So all autoimmune disorders would give you a increased risk of occurrence of peripheral as well as coronary artery disease. Why would that be? Why should an inflammatory disorder cause increased risk of coronary artery disease? What is the pathophysiological grounds of the same? Inflammation
Indirectly,
as
they
the
are
missing link
asking
of
inflammation
atherosclerosis.
leads to atherosclerosis and how?
Okay, tell me any therapy that you know, Dr. Damini, which has been used to treat inflammation in coronary artery disease. Either a new therapy or an old therapy. Both will be okay. You get that marks for answering either of the two. One old wine in new bottle or a new wine itself.
The vitamin E and
No,
bempedoic.
that is not anti-inflammatory. Colchicine. In Colcott trial, you had recently colchicine coming in, showing the data of now it's been actually approved. If you look at the FDA approvals have just come in. And canakinumab in CANTOS trial, which was used again in the acute coronary syndrome, where they found out reduction in CV events, especially mortality, but mortality was reduced more often by reduction in occurrences of malignancy. And that's why now they believe that the inflammation is the missing link between atherosclerotic events and malignancy. So their Paul Ridker's group is now evaluating use of canakinumab in malignancy as a vaccine against malignancy.
Yes,
So that's
you're
how the
perfectly
thing.
correct.
There's
Very,
growing
very important
interest.
issue in anti-inflammatory drug. These are the things anti-inflammatory drug, as well as coronary, as well as other rheumatoid arthritis, other things.
There is some growing interest of the use of interleukin 6 antagonist as well, ziltivekimab. It is being explored in a few trials, even with heart failure, that's Hermes. And there is an upcoming trial for correlating, I think, so that's Poisidon trial that would be linking it with atherosclerosis and ACS events with inflammation. So this is actually the missing link. So a lot of patients, those who sir was asking about therapies. Do you know of any standard prescription that you use a therapy that is anti-inflammatory, additional anti-inflammatory action, something that has got pleomorphic active action? You are using it routinely.
Before that, you have to understand you have to diagnose the activity of the disease. This is very important. If the activity of disease, that case is the inflammation going on. So that case is definitely this drug oil already Dr. Sharma mentioned, colchicine, other things, clonazepam is very, very useful drug. Of course, Takashi arthritis sometimes most of the cases, more than 90% cases when patient reaching to us is burn effect of the disease. Only the 10% cases some activity may be present. So that activity is very difficult to diagnose. Is ignored when the low graded fever and this arthritis mimic like the tuberculosis-like features, revealing rise temperature, and only examination carotid artery tenderness is available, all the arterial tenderness there, then you think clinically think that is possibly patient having the arteritis changes, activity of disease. So that should be confirmed. So particularly nowadays, imaging is very important issue. OCT and IVAS also may very guide. Peripheral IVAS and OCT is very useful. In case of coronary, just like that, you have to assess the vulnerable plaque. OCT is very important. Plaques should be thin, less than 0.6 micron, and the infiltration of macrophages and T cell can be detected by the particularly index of suspicion must be there in cases of OCT. You have to understand diagnosis vulnerable plaque as a whole. So that is the way we can differentiate whether it is Takashi arteritis, is a panarteritis, or whether atherosclerosis. Atherosclerosis is only intima media. So that is all very important diagnostic purpose. Okay, Bhatti, anything? Go ahead, please.
Yeah, fine, sir. Okay.
Okay, so
We
Dr.
can.
Damini, you can proceed to examination.
Okay, sir. Thank you. So on general examination, the patient was conscious, well oriented to time, place, and person. He was comfortable and cooperative. Skin, hands, fingers, faces, posture didn't have any deformity. Eyes were normal. He was afebrile on touch. Pulse was 64 per minute, regular, normal volume and character. Respiratory rate was 60 per minute, thoracoabdominal and regular. Blood pressure was 124 by 86 millimeter of mercury with saturation of 96% on room air. The journal marker of disease like pallor icterus, cyanosis, lymphadenopathy, and edema were absent. On CVS examination, on inspection, the chest wall was bilaterally symmetrical, elliptical, and JVP was normal. No abnormal pulsations or hepatojugular reflex was absent. There was no parasternal shoot or any abnormal pulsations noted. On palpation, apical impulse was normal in character at fifth intercostal space, mid-clavicular line. On auscultation, S1, S2 were heard, and there were no added sounds or murmur heard. On peripheral pulse examination, it was only the brachial pulse of right hand side which was palpable uh, at the rate of 68 per minute, regular, normal in character, and feeble in amplitude. It was normal condition of arterial wall. There was no hardening of vessel wall noted. On local examination of limb,
So how do you appreciate when the pulse is not palpable? How would you appreciate the arterial wall?
so the brachial was palpable on right side.
How do you assess a condition of arterial wall, by the way?
Sir, we try to roll on the hold the vessel and try to roll on it and feel if it is hardened or normal vessel.
How do you do that?
Sir, we roll over the artery after
No, so there has to be some technique, no, of rolling. Or Osler's. Have you heard of Osler's maneuver? Osler's maneuver?
Yes, sir.
You have to occlude the artery first, and then only you can feel. In a pulsatile artery, you need not. So your answers for the otherwise also should have been, because the it's not the arteries to be palpable that you will be required to look at the condition of the arterial wall. Because even otherwise in Osler's, what you do is inflate the blood pressure cuff above the systolic and then try to roll the artery. If you can feel it like a cord, then it suggests that there is involvement of arteriosclerosis or Mockenberg's degeneration. Other thing is that in patients with aortoarteritis, the arteries that usually undersized. So the characteristics are often like of a bead if they are palpable at all.
Okay, sir. Ji, sir. So on local examination, on inspection, both the legs are hanging by the side
So
of head.
you are going to speak about the back examination later, or
Sorry, sir.
you've not examination of back?
No,
Dr.
sir.
Panja used to scold us when we were not to speak. I remember one of the candidates being scolded. Did not look at the back? Why? Because that's where you'll hear most of the bruise. That will tell you where the lesion is. That will you auscultate, you palpate, and the back is the most important examination part apart from the arch. So renal bruise, you have to be paraspinal. You have to keep going down. So have you covered that separately or no?
No, sir, I didn't.
No, so that's something that you should not miss out. That those are the simple things which we often tend to overlook, and these are the things that I learned only in exam. So one of the other candidates, Dr. Panja, was examining in DNB. He told you've not looked at the back, and then he auscultated and gave him where the bruise was, and that's where the stenosis was. Dr. Panja, you're muted, sir.
And then the right upper limb, right or left, is difference or not. It is maybe atherosclerosis, maybe arteritis, but keep in mind, a coarctation of aorta surgery, plasty in the radial pulse, left pulse is reduced. So that is also keep in mind. This is very important. Coarctation after surgery. Okay, proceed.
Yeah, Dr. Damini, proceed.
Okay. On local examination of left lower limb, nails show transverse ridges and are brittle. Loss of hair over the left calf is noted, and coldness on palpation of left calf, leg, and foot. There was no apparent wasting of muscles that could be appreciated. Burgess angles of vascular insufficiency was 45, and the sunset point, sign was positive. The
What is
capillary
sunset sign?
Sir, when the patient is sitting and gets up, the pinkness of the skin, that is the refill of the peripheral vessels, is usually seen immediately. But in patients with peripheral arterial diseases, the refill is delayed.
That same as, reflects the capillary filling time and circulation
Yes.
time, right?
Yes.
There is astonishing finding. Pressure is normal, 120 versus 80, and then no diabetes. another important, no other risk factors. So only the atherosclerosis is responsible to explain everything very unreliable. You see,
But
there
sir,
should be hypertension, there should be diabetes. So that type of coronary disease as well as combined with perivascular disease is absence of comorbid condition, very, very rare.
so the patient was a chronic smoker also.
Okay.
So what are the factors that you are saying it's likely to be atherosclerotic? One, smoker. Second,
So the age, and
age,
then he has already had a coronary event. So
and had a peripheral event and has a history of peripheral PCI,
peripheral.
I mean PTA.
Yes, sir.
And
Hyperlipidemia
do you
not,
get Hmm.
you have not mentioned that is a lipid value on these examinations. Oh, you are doing the only clinical examination now, not investigation. Okay, go ahead.
Do you get signs of is gangrene more common or less common in aortoarteritis compared to atherosclerosis? Or same? Loss of limb is more common in atherosclerotic or in aortoarteritis?
Sir, it is more common in aortoarteritis.
Is it?
Sir, I think so. I'm not sure.
Less. Most of these guys keep moving around with a thinned out limb with with claudications. They don't use loose limb. And what Dr. Panja is mentioning, that's the very reason. A lot of the atherosclerotics are diabetics.
Yes,
Most of these
this
people don't
bone.
have a good collaterals. What the aortoarteritis, what though it's a panarteritis and though the vasa vasorum is involved, they usually tend to have good, at least sustainable limbs. That's why these people keep on getting PTA and another PTA and then the drug-eluting balloon, then another stent, then a stent will get occluded, then they will put another drug-eluting balloon and then do a PTA. So Dr. Panja as a patient, he's operated like 6 times. Dr. Panja, I remember you doing that
It
case
is true. It
presentation.
is true. It is most of the cases may happen multiple vessel disease. So
Yeah.
particularly atherosclerosis, if you keep in mind what an interesting finding, the below the renal artery involvement Takashi is rare. Below renal artery involvement Takashi is rare. If it is renal artery involved, particularly if it is iliac artery, femoral artery, iliac artery, all these below the knee artery, all the atherosclerosis. This is very important.
Okay, sir.
Okay, go ahead, Dr. Damni.
Uh, on the right lower limb, nails show the transverse ridges and are brittle. There are no apparent signs of wasting, and the sunset sign was positive in the right limb too, but the capillary refilling time was 8 seconds. On CNS examination, the patient was right-handed, well oriented to time, place, and person. The memory was intact, normal word output comprehension. GCS was 15 by 15. All cranial nerves were intact. And on motor examination, there was normal nutrition, normal tone, and the power was 5 by 5 in all 4 limbs. The reflexes, superficial and deep tendon reflexes were all intact. These were the some baseline
So
investigation that
wait. So you'll have to go back to the diagnosis. So this is where you finish, and then that's when your diagnosis comes in. So what's your diagnosis?
uh, sir, according to the history, I would provisionally diagnose this patient as to be a case of peripheral arterial disease, who has already gotten acute coronary syndrome, and he has a risk
Oh,
factor
so
of
now you'll call him what? Acute coronary?
now
Will you
now
call him
it's
chronic coronary?
coronary artery disease.
Or what is chronic coronary disease? Chronic coronary syndrome, CCS. Have you heard of that?
What are the presentation of a chronic
You have
coronary
acute
syndrome?
coronary syndrome.
How
Same
will
way you have
define the
chronic. Do you
chronic
have
coronary
chronic
syndrome?
coronary syndrome?
Sir, in which
90% of
patient?
coronary disease, yes, 90% of coronary disease, chronic coronary syndrome. Acute coronary syndrome is that only 10% cases. So therefore, how will diagnose the coronary syndrome? Very important.
Sir, in coronary patients would like they will have a acute episode and then might have anginal or this anginal
What
symptoms
is
or
definition? Do you know or you don't know of CCS? Chronic coronary syndrome. How is it defined?
sir, I don't know the definition. Sorry, sir.
Oh, you have to know the
Anything.
8 points is there. 8 points already there. So go through it and brief when the patient gets first time getting the pain. Second thing, keep in mind some group of patients dyspnea, difficulty breathing, but no chest pain. So LV dysfunction, deranged. So you have the index of suspicion chronic coronary syndrome. Third thing, COPG done. After 1 year part is some pain, that is also chronic coronary syndrome. Or intervention done, and sometimes getting pain yearly, that is also chronic coronary syndrome. And variant angina, that is also, this variant angina, that is mental angina, that is also called the chronic coronary syndrome. Another spasm, any arterial spasm is also coronary. A microvascular disease, particularly in women, large coronary vessel disease. But usually in women coronary disease, peculiar is that the large coronary normal, that is microvascular disease, that is also chronic coronary syndrome. So these are the 8 criteria to diagnose chronic coronary syndrome. Please keep in mind.
Okay, sir. Thank you, sir.
Why is it important?
Yeah. Pardon?
I'm asking Dr. Damini as to why is it important, Dr. Damini, to know whether it's a chronic coronary syndrome? Do we have any specific treatments for chronic coronary, or we don't have? Or just
Sir,
the definitions that we need to learn as a student?
according to the symptoms that the patient would have, if it's anti-anginal drugs we can add, and for dyspnea we could
So
add.
a case of peripheral vascular disease with chronic coronary syndrome would qualify to one drug, which comes in 4 doses, and one of the doses used in chronic coronary syndrome. Can you tell me the name of the drug?
Sir,
I've given you enough clues.
statin could be.
No, rivaroxaban. Now tell me the dose required of rivaroxaban in chronic coronary syndrome.
Very, very important. That is the only account they are all newer anticoagulant. The established studies, there is very
Sir,
important drug.
yeah. So rivaroxaban we can use in 2.5 mg dose for the chronic.
Your BD or
Have you studied
TDS?
the river flow study? Have you started any trial, a river flow trial? Have you come across?
No, sir.
Okay, go through it at home. So that
Okay.
is very
Compass
important.
trial, have you heard of? Voyager PAD. So these are the important trial. Voyager PAD trial, Compass trial. Most of these patients had improvement. Peripheral vascular disease, acute limb ischemia. Voyager PAD showed that the limb MALE rate, like you have MACE in coronary, you have MALE in PVDs. MALE is major adverse limb events. Major adverse limb events were reduced in Voyager PAD in patients on rivaroxaban 2.5 BD on top of aspirin. And the same is also the case in Compass trial, where it's a CCS setting, not an acute limb ischemia setting. And CCS, when you give 2.5 BD of rivaroxaban on top of aspirin, you would end up preventing 50% strokes, which are the most common modality of mortality in a patient of CCS, with overall event rates reduced also significantly. Then there are some more trials like atlastomia, in which are not pertinent to our current setup, but atlastomia, etc., were more often the acute coronary kind of a situation and from the coronary perspective. But you never had any other trial or any therapy in peripheral vascular disease to tell you mortality reduction. So probably it's very important to know, because no books have mentioned it yet in terms of the books that you read for your exams. But it's very well published, and every examiner would know this. That's why you should know of role of rivaroxaban 2.5 BD in patients with peripheral vascular disease.
So you, previous drug, you keep in mind silostazole. Silostazole, very important drug. Pentoxifylline, is also important drug. So these are the two important old drug nowadays able to use it.
So your diagnosis should. Yeah, sorry, Dr. Tanush, please
What is
go.
the dose of pentoxifylline?
Sir, we use it in 400 mg TDS.
Okay.
What's its side effect and mechanism of action?
Pentoxifylline is, sir, it acts by vasodilation and
No,
hence
it squeezes out something from somewhere, and there is a scientific name given to it.
Oh.
sir, vasodilation.
Rheology. What do you mean by rheology? Rheology. Rheology is a science of flows. What it does, it deforms the RBCs to an extent that they become more flexible to squeeze through the lesions. So the RBCs can pass through a stenotic lesion, including the collaterals. They become more flexible, as you can see, or deformable, and they pass through the stenotic segments. That's the mechanism. Hemorrheological property of RBCs is modified by pentoxifylline. Side effects?
Aware of the side effects.
So it does it improve? What does it improve? Does it prevent amputation? No, it just improves your claudication distance.
Yes.
What it does, it improves claudication distance. It improves. Okay, so because we have come to this claudication distance, my another question is: suppose you have a patient who's got Boyd's this patient, and suppose he has Burgess disease. Will you do lumbar sympathectomy?
Sorry, sir.
Suppose you have a patient of thromboanginitis obliterans. You know that
Yes.
TAO? Yeah. So in a patient of TAO who has got no rest pain, but only claudication, grade Boyd, whatever the patient is having, no rest pain, would you be advising lumbar sympathectomy? Lumbar sympathectomy, you know, right, is one of the treatment for, yeah. So would you advise somebody without rest pain to undergo lumbar sympathectomy? If yes or no, and why?
No, sir. We would first go for pharmacotherapy and
Go. So why is lumbar sympathectomy contraindicated? So you will not advise. Is contraindicated in a patient who does not have rest pain. Why? What will happen to his claudication distance?
sir, along with pain relief, it might also result in
No. So
impotence.
lumbar sympath, yeah.
Sir, in other symptoms like impotence and
No. That's not the reason. You
sympathectomy
should know pathophysiology. What happens when you do lumbar sympathectomy? What happens to the flow from where it goes to where? What happens to the line of demarcation? What happens to the gangrene? Will it relieve rest pain or not? Those are basics, pathophysiological redistribution from skin to muscles, right? Okay. So your diagnosis, when you speak of, you should speak of etiology, severity, extent of the disease, and its complication. Can you now reframe your diagnosis in this patient?
peripheral arterial disease, the etiology being most likely
Hello?
atherosclerosis.
রাত 10টার সময় ফোন করবেন ব্যস্ত
And
আছি
Chronic
severity,
coronary syndrome, history of chronic coronary syndrome.
yes.
It is important because that will go with what risk factors?
Risk factors,
Hypertension,
smoking and
dyslipidemia, okay, and
Smoking.
complication. Does he have a gangrene?
no, sir.
So those things, right? Pre-gangrene or gangrene or other complications with it. You know that that's any diagnosis when you speak of comprises of these aspects: etiology, at pathological locations and extent, associated risk factor, presence of complication, and what is then required. So what will you do for this patient?
Sir, in this patient, as of now, as the patient presented with the following complaint, and we got further investigations. So
How
we,
would you diagnose it further?
sir, we'll get a CT angio. Further investigations we would need because the patient already has history of many angioplasties done. So we need a repeat
So
assessment of.
before he goes for CT angio is something that you can do in your outpatient clinic itself.
Sir, we can check for ankle brachial index, or we can check clinically
Yes.
if the pulsations.
Doppler, simple Doppler, handheld Doppler. That's what the surgeons do, right? When
Yes,
you
sir.
send them for some patient for embolectomy, what do? They just look at what pulses are there, arterial Doppler, venous Doppler, simple Doppler rather without ultrasound. And then, of course, you can ask for an ultrasound because that's what you can, in a peripheral examination, just like fundus required in neurology, a peripheral vascular disease requires you to be assessing Doppler assessment of the arterial and venous phase. Why is it important? Venous phase also?
Sir.
The gradings, any gradings that you know of ischemia based on venous filling present, absent? So you may have acute limb ischemia, especially acute, not so much of chronic, Where you don't have even venous fillings is a dead limb. The surgeons would say, I will not do the embolectomy. He will say it'll go for abdominalysis, acha nahi hai, limb is already gone, That's why what they look, the viable limb versus a salvageable versus a non-salvageable limb is defined by presence or absence of venous Doppler signal, not so much of arterial. Arterial absence would always be there because it's an acute limb ischemia. So when you refer to a surgeon, he will come in more interested in the venous Doppler. If you're getting venous filling, means the tissue is still metabolizing and working. That's the case that he will take up for an embolectomy. And that's why, just like your cardiovascular examination is not complete without ECG X-ray, same way your peripheral examination is not complete without a handheld pen-shaped simple Doppler. You need not even do an ultrasound. That's what you should know. Of course, ankle brachial you already mentioned. And you can then, of course, send for an ultrasound, USG QB, USG of the limbs as well as arterial Doppler by a radiologist to confirm the extent. And because that's the advantage, being no contrast required, these patients may end up with contrast nephropathies, diabetic, hypertensive, elderly. So before that, you should have a
Yeah.
Doppler done. And then, of course, you can do a CT angiogram.
So
Correct.
peripheral artery disease, carotid must be assessed, atherosclerosis or whatever may be. So carotid Doppler stat is very, very important. The intermediate thickness can be assessed by the color Doppler duplex. This is very important. Sometimes ultrasound, there is the renal artery involvement also there peripherally. So that should be USG very helpful for diagnosis of the arteritis or the atherosclerosis narrowing, or it is a fibrovascular dysplasia. This is very important diagnosis. Okay, next.
So these were some baseline investigations that we performed for the patient. Patients' baseline investigations were more or less in the normal range.
HSCRP?
Yes, sir. The HSCRP is raised.
TLC?
So the TLC count was progressively increasing initially, but then it was decreasing the last.
So as sir very rightly mentioned, you should be very, very observant about any superimposed acute limb ischemia episodes, what you were trying to define by the Rutherford classification, what sir was mentioning on the basis of arterial venous. So because these patients, when they present to you, they are having some aggravation of their symptoms. That would be there. And as sir was trying to hint you many times, the identification of chronic coronary syndromes, when they are progressing, it's very difficult because the patient is not walking. You will not be able to diagnose because the patient already has limitation of their activities. So you have to be very cautious. Okay, go ahead.
So another two investigations must be done in case of peripheral disease. The APLA, very, very important. You see, so APLA syndrome. Another important Bianca, Shanka, also we definitely should be assessed. And then third is the homocysteine. This is also early premature atherosclerosis, and vitamin D3 also must be assessed nowadays. There's a few points to be keep in mind, particularly in young patient.
Yes, sir.
Okay.
So this was CT scan for abdominal aorta and lower limb angiography. Atherosclerotic changes were seen involving suprarenal abdominal aorta without narrowing or stenosis. Atherosclerotic wall calcification was seen involving infrarenal abdominal aorta, causing 10 to 15% of luminal narrowing. The celiac artery, SMA and IMA appears to be normal. Stents were seen in bilateral common iliac arteries as the patient has underwent the PTAs. The left-sided aortic arch was seen. Stent was noted in left subclavian artery and its origin from the length of 34 millimeter. Stent is patent and shows normal opacification. Bilateral subclavian, left axillary and brachial arteries appeared normal in course, caliber and opacification. Left brachial artery was normal. Left proximal radial and ulnar arteries were also normal. Bilateral vertebral arteries were normal in opacification and the proximal part was also normal.
Okay, stop here. Stop here. Go back. What is contradictory between your physical examination and the CT scan?
Sir, on examination we got only axillary vessels to be
Axillary?
so brachial vessel to be
Which brachial?
But here the subclavian artery and is patent, and axillary artery is also patent.
So how do you think, how can you go about explaining absence of pulse in right radial, left brachial, left radial? Try to think.
the
How can you explain the absence of pulse in right femoral? You are saying the stents are patent. Okay. So you said the patient has underwent previous angioplasty as well,
Yes, sir.
the coronaries. Maybe the right radial approach would have been used earlier. So right radial could be absent because of that. Maybe the patient underwent left subclavian angioplasty earlier. Maybe because sometimes CT angiogram is not very confirmatory, especially in post-stent patients. You might not have a good visualization of the lumen because of the superimposed stent structure. So you need, what do you want to do ahead? Okay, go ahead, let's see.
Sir, for the left side, there were atherosclerotic wall calcifications seen involving external iliac and internal iliac, causing 10 to 20% of luminal narrowing. And the stent was seen in proximal portion of left external iliac. Atherosclerotic changes were seen in the stented portion, causing 15 to 20% of luminal narrowing. The non-opacification of distal left external iliac artery and CFA is seen suggestive of complete thrombosis in the vessel. The graft is seen across the subcutaneous portion of lower abdominal wall, extending from right superficial femoral artery to left superficial femoral artery. Diffuse mild narrowing of left superficial femoral is seen, causing 30 to 40% of luminal narrowing. Critical stenosis was seen at the junction of left distal superficial femoral and popliteal artery, causing more than 70% of luminal narrowing. And the left popliteal artery appears to be normal. The left ATA, PTA, dorsalis pedis, and peroneal arteries were normal. On the right side, atherosclerotic wall changes were seen involving external iliac and internal iliac. 10 to 20% of luminal narrowing was seen. Post-operative changes involving right common femoral artery, leading to mild circumferential wall thickening and narrowing of 10 to 20% was observed. Right superficial and deep femoral arteries appear unremarkable. The right ATA, PTA, dorsalis pedis, peroneal arteries are unremarkable. So this is the image of CT angiography of lower limbs. I've tried to label the findings that we got. This is the stent in the bilateral common iliac arteries. We can appreciate in the figure. And there were atherosclerotic calcifications seen in external iliac and both in external iliac and internal iliac. And here we can see there is a stent in proximal portion of the left external iliac artery. And here there is non-opacification of the distal here on the fourth mark, non-opacification of distal left external iliac artery and common femoral artery, suggestive of complete thrombosis at this area.
Occlusion.
Occlusion, sorry, sir. And here we can see the on the fifth mark, the graft across the subcutaneous portion of lower anterior abdominal wall extended from right SFA to left SFA. And here on the sixth spot, we can see critical stenosis at the junction of left distal SFA and femoral artery, which is more than 70% of luminal narrowing. This is another image of angiograph. This was the ECG of the patient as he has already had a coronary event. So we can see QS pattern in V1 to V3. The echo of the patient was RWMA was seen, basal to mid inferior wall was hypokinetic, concentric LVH was seen, and the ejection fraction of the patient was 50%. So we got a lower limb angiography done on 13th of April 13th of June. So here we can appreciate the narrowing or the stenosis seen in the fluoroscopy. The fluoroscopy also shows the stent in right common iliac artery and left common iliac, and the suture at the site of anastomosis of femoral bypass. It is patent. Here is the suture. The angiogram taken in abdominal vessel reveals critical, that is 95% stenosis in the stent placed earlier in the right common iliac with patent femoral graft and mild disease in right external iliac artery. So the patient was advised PTA to right common iliac artery. And after we did the procedure, we can see the flow. Under aseptic precautions, the patient underwent the PTA to right CIA, and the patient's right brachial artery was punctured and 6 sheath was inserted. Heparin 75,000 international unit was given, and the lesion in right CIA crossed with 014 filter FCPTCA wire, and the stent was placed in the right common iliac artery.
So
And
is the filter commonly used wire, or you have some dedicated wires that you're aware of for peripheral? Just because you're mentioning the wires, I'm talking.
No, sir, I'm not aware of the wire.
It's a coronary wire, but you, of course, can use it. And there are dedicated peripheral wires that are there. Okay, good result. Fine. So how's the patient doing? Tell me the discharge treatment for this patient. What is the patient on? Now you should include what I told you, CCS therapy.
So the patient was on antiplatelets and we started the statins.
Rivaroxaban 2.5 BD, statins full dose.
Yes, sir. And we also gave him diuretics and beta blockers as his ejection fraction was
So are
also.
beta blockers contraindicator, or you can give in PVD?
So we can give beta blockers in PVD.
Yes, we can give, because most of these patients, they die of coronary rather than die of PVDs. And most of them especially have an underlying atherosclerosis. That's why you need to treat that as well. So the beta blockers are not completely no-no, especially in atherosclerotics, but otherwise probably yes, if it's a more of the previous theories of spasms and unaffected alphas after you block the betas. But
Yes,
that does not mean it's a contraindicated, right?
so
Okay,
we also
was that your last slide?
Yes, sir.
Okay. So I think you did well. Dr. Panja, your comments, and then we can have the expert talk as well. Dr. Tanuj?
DNB student, different Mr. Parks. Okay.
I'm just
All right.
feeling very happy that she presented very well.
Yeah, well prepared.
Okay.
So we move to the expert talk now on aortoarthritis.
Okay, give it. Okay. Should I connect, Sanma?
Yeah, Dr. Panja, please share your slides.
Yes, I can see the further review. Yes.
So as you know, we have designed the modules in a fashion that includes practically all the cases that are asked. So this was in that series. We've already done a case of rheumatic, then we did a case of acyanotic congenital, then next we had a case of Eason manga. In case you've missed out, you can go back to the recordings, you can ask, or you can check them out on YouTube. And we move to Dr. Panja's presentation.
Yes.
Dr. Panja, I think you've shared multi-vessel PCI, and that's probably
Okay.
not the. Is that the case you present?
No, I present. No, actually wrong PCI.
Yeah, that's the wrong one. I
Okay,
thought
that is the thing.
you were presenting on
Arthritis. I told you.
peripheral vascular.
Next one. Not the SARC and RCA. NLDA. No. These not cases. These the old 90 years old. Multiple vessel disease. I'm not going to discuss. I will present on arthritis. Next.
Yeah, so Dr. Panja's aortoarthritis presentation as it comes through.
Yes, on present.
Dr. Damini, your final year?
Yeah. Talk it.
You're muted.
Multiple. Yeah.
No, sir, she's not in final year. Right.
Okay, please present.
Good. She still has time to.
Please
sure,
present
she's
your
learned. Yeah, Dr. Panja, please go ahead.
Let him present.
And Mr. Kanu, can you check if Dr. Marjan is joining?
No, sir, actually he's not joining. I think it's stuck some problem.
Acha, acha, no problem. I'll try to make up for him.
Peripheral 2. That's this one. That's one. Yeah.
This is
Yeah.
taxoid.
Yeah. Yeah. Okay, just 1 minute. I can. Okay.
One second, I'll share the.
Yeah. So this is very interesting case. Am I audible to you? Come on.
Yes, Dr. Panja, you are audible. PCI and aortoarteritis in multivessel.
Yeah,
Please
sure.
go ahead.
It's
Yeah,
very, very
please go.
important case. Just 1 month before, I done the intervention in this patient when the coronary involvement there. And so this patient, 32 years female, hypertension, dyslipidemia, opposed dyslipidemia 110 LDL, cholesterol 250, and triglyceride 175. So that is one to emphasize, therefore not too much atherosclerosis perhaps because of that type of dyslipidemia. And continuous chest pain, shortness of breath, no history of claudication and family history of coronary disease. And unequal pulse and upper limb, both right limb blood pressure 130, systolic and left side 180, and non-specific ECG changes, echo 55%, and TROP2 negative, ESR high, C-reactive protein, and Pianka-Schenker negative. So it's a clinical diagnosis of the Takashima because of unequal pulse and female patient. And just to describe the case, then I'll talk to you. And here is lemon stem disease, very, very interesting. Ostium of the LMCA is 99% block. However, interesting, it is class 2. According to coronary classification, LAD is 90% block, and the SARC proximal also 95% block. Are you, my slide is visible to you? Come on.
Yes, sir, it's visible.
Visible, okay.
Yeah.
So both LMCA, ostial, circumflex, proximal, and LAD 95%. So this is the angiography. This is very right arterial normal. So this is very unusual feature for presentation of the cases of Takashima arteritis because it's class 3. You see, look at the angio, arch angio. The right subclavian is 95% block, and origin of the right carotid also narrow, and left subclavian also more than 90% block, and even the origin of the vein also involved from the subclavian artery. So that is very important management point of view. What will arrange the patient? Because patient multiple vessel disease, patient multiple peripheral artery disease, do you give to surgery or intervention? Because we're thinking whether, though there is no activity of disease, in that cases, I think that the coronary intervention will be better option in this patient. And there is not too much pain on the right and left upper limb, so I not bother for that at present moment. Because this lady presented with bank employee, present acute coronary syndrome, severe pain. Now renal artery also normal. So we have, but technique is that when there is the circumflex as well as the LAD and RCA ostium block, so technique is that we have to dilate the first, the small passage of the ostium of the LMCA must be done. Then we proceed for the SARC and LAD. So I'll do the stent at the end of the procedure of LMCA, and LMCA ostium will be take care later on. Only the balloon dilatation done of the ostium of the LMCA so that where can we cross easily, and both circumflex as well as the LAD. So here the wire, we put the wire on the aorta so that prevent the blocking of the guiding catheter to the ostium of the LMCA. So always when the guiding coming on the sinus, she getting hypotension pain. I giving the arch on one of the wire which is going to the ascending aorta up to the left subclavian to get the proper position of guiding catheter. So the wire on the circumflex, and then the balloon dilatation of circumflex first. Of course, before that, I already dilated the ostium of the LMCA. One is 2 size balloon, then subsequently 2.5 size, so that to get the lumen is properly approachable to pass the guide wire, and sometimes guiding catheter may touch the ostium that prevent the hypotension and pain. Okay. So first I put the stent in LAD, balloon implantation, and then I put the stent, and subsequently, stent is depleted. It is 30 millimeter stent, long stent, because this type of coronary disease is very rarely associated with osteal lesion in case of Takayasu arteritis. This is I record done the angioplasty in the Takayasu 51 cases. This is the first time I getting the osteal lesion along with the both LAD and the circumflex. So stent on the LAD. Now stent on the circumflex, balloon circumflex, then followed by this stent on the circumflex. So both the vessels now dilated and unstented, both LAD and the sarc is dilated. Now we have to do the angioplasty of the ostium. So technique, we have the post dilatation there. Now technique is that I already dilated the ostium again 2, and subsequently 2.5 balloon, small passage there. Now I giving the cutting balloon. So cutting balloon I giving the, and 1/3 of the cutting balloon outside in the aorta, outside the ostium of the LMCA. So this is very important. So there is 2 times different angle rotation. We have dilated, we have cut the ostium because it is not athermal, it is the inflammatory plaque, very difficult to dilate, very difficult to, you have to take care of the cutting balloon. After that, this is the result, now I'm doing the flaring of the mouth of the ostium of the LMCA. So proper position is done now, and 2 millimeter outside the ostium, that is 2 millimeter of this. So proper position is very important. You see here, to get the proper position of the stent, onyx I given it because a chance of response is very high, and here stent at least around 2 millimeter stent outside the ostium, and the proper position, then deploy the stent. Now stent going to deploy. So therefore, boost sign, that is a proper inflation because IVAS are not done. So this the boost is shows the proper expansion of the LMCA stent, and this 2 millimeter outside the ostium of the LMCA. So this is the result, excellent result. Patient 32 years female, there's no activity and only acute coronary syndrome, very, very rare in my study. That is the associated other vessel involvement is very rare in these cases. And patient actually discharged Brilinta and aspirin and rosuvastatin 40 milligram. We have to give the steroid 30 milligram and methotrexate 12 milligram. Then gradually taper up to 6 months. I will continue because the case of arteritis, though there is a burn effect of disease process sometimes waxing and waning, go on. Sometimes inflammation again come back once again. So therefore, if the inflammation, the chance of response is extremely high. 50% in my series, we have done the 51 cases. 50% cases restenosis within 6 months. So that is why we continue the corticosteroid as well as methotrexate. So final Takayasu arteritis is a chronic inflammatory disease in young female without known cause. A patient with critical hospital stenosis LMCA found along with the SARC and LAD in Takaisu, which is extremely rare. In this patient, successful PCI is performed with excellent result. This is an evidence that instant response compared to CABG is very high. The CABG is not preferable as the patient is young and due to narrowing of the origin of the LMCA. So that is the how I've done the CABG. Then I just couple of slides for peripheral vascular disease. We have done the angioplasty 20 years before. The gangrene of the lower limb, left lower limb, you see, we are below popliteal knee, there is severe calcified popliteal artery. The cutting balloon, medial cutting balloon is used and then restore the normal circulation lower limb and gangrene is improved. There is 13-year-old girls. So it is not a arteritis, some congenital aneurysm that treated by the cover state. And this is the case of Takaisu arteritis, angiography of the right subclavian, left subclavian block, aneurysm of the left subclavian artery, and even arch of the aorta also grossly narrowed, mimicking like the coarctus on the aorta. So this is the interesting case. The patient arteritis, bilateral renal stenosis, just a renal aorta severely narrowed. What is then a chimney-like stent I put in the right renal artery, left renal artery, ultimately giving the one stent on the abdominal aorta. The excellent result. Patient, he have done that at the age of 12 years female. Now she is 35. He has given child, give birth the child, blood pressure normal. This is a very interesting case slide. Perhaps Dr. Sharma has seen it. I presented it 20 years before. The patient recurrent syncope, 7-year girls. He recurrent syncope, 7-year girl, carotid tenderness, right side. We have done the angioplasty, the total occlusion of the right carotid artery. We have done open the artery with the help of the coronary artery. But after 12 years, you see, and this narrowing of the artery, right artery, right carotid artery. Then you give the stent on the right side. So patient doing well, no problem. This subclavian artery block, so already it should be stented properly, and the iliac on the right iliac artery and particularly dilated, and we have given the stent the right iliac artery. And this is a very interesting case, stuttering hemiplegia. It is there. It is not arteritis, in case of atherosclerotic. The internal carotid 95% blocked there, and after putting the stent, patient doing well. So again, subclavian artery after putting the stent, intermittent claudication level fully appears. Thank you very much. I think these couple of slides will be helpful to you.
Thank you, Dr. Panja. It was wonderful to look at the coronary involvement, which you've been stressing to be ruled out in aortoarteritis.
Okay.
So also you have shown a couple of cases
Yes.
of intervention that different vessels are involved. And so also the role of immunomodulators that you talked about in acute phase, to put them on steroids, methotrexate, which is the common combo that people use. You can also use mycophenolate mofetil. Previously, it was a very costly therapy. Now people use it very often. So also sometimes at CQS as the other immunomodulator. In a couple of cases, I remember using endoxan as well in patients who were intolerant and recurrent lesions over there. So with that, Dr. Panja, any other closing comments? And then we can have Dr. Tanu's closing comments.
Dr. Bhatia is going to present some cases.
Yeah, Dr. Bhatia, please go ahead.
Okay, please present one case.
Yeah, Dr. Bhatia.
Yeah.
So am I audible?
We have to finish by 9. Yeah. So we are staying in the preview room of the Hyderabad conference. Yeah.
Yes. Am I audible, sir?
Yes, Dr. Tanuj, please go ahead. Share the screen.
Okay. So it's more of a question to the residents because I wanted them to attempt this. Yeah. So this is an angiogram. It's kind of a spotter for them. I want them to attempt what it is. Dr. Damini, are you online? Not yet.
Am I audible?
Can you make full screen, Dr. Bhatia?
Yes, sir.
I think we have connectivity issues with Dr. Damani, is it?
Sir, just give me a moment.
Yeah, sure.
Yeah. So, this is the, sir, I think so some audio problem. Just
Yeah, I think what we can do, Dr. Tanuj, is maybe you can go ahead and present what it is rather than asking.
yeah, just a second.
Because
Sir, I'll stop.
there is an echo between yours and Dr. Damini's audio, it seems.
Sharing and reshare it. Just a second. Yeah. So this was a case I think wanted to exemplify the importance of the angiographic assessment, especially for the resident. So this was a angiogram of the right vertebral artery that showed the retrograde filling of the left vertebral artery, something that is commonly called as subclavian stele. And hence means I'll go to the actual case where I'll show. Just a second. Yeah. So I would be discussing the case of subclavian stele, the importance of detection and management. So my first case is a 64-year-old male presented to us with left-sided hemiparesis taken up for carotid angioplasty. And this is the critical lesion in the carotid, and the carotid intervention was planned, pre-dilated with a 4 into 10 mm balloon. You can see the balloon traversing the critical lesion, and the exact 8 into 640 stent was placed and deployed, and we achieved a good result. Just that after the intervention, we took a right-sided vertebral angiogram, and that revealed the critical lesion in the left, that revealed the subclavian stele, and then we cannulated the left side and we found a critical lesion, and that was the subclavian total occlusion that was handled with additional stenting across the left subclavian. It was a difficult retrograde crossing, and initially the wire was going into the dissected plane, and with a simultaneous approach from both the sides, from the femoral as well as the left radial side, we were able to kiss the two wires, kiss the two catheters, and then thereafter did from the true lumen to the true lumen and did a pre-dilatation and deployed a OmniLink 9 into 39 stent, and this was the final result that we achieved. My next case is extremely peculiar. It was a post-CABG patient. Why I'm presenting this? Because post-CABG patients, symptomatology, especially with relation to the peripheral as well as coronary, it's an overlap of a syndrome. So this was a post-CABG patient presented to us with history of left upper limb claudication, followed by classical angina, followed by even a loss of consciousness that was just transient. The left brachial was feeble, and even the patient had complained that his blood pressures were unequal in both the arms. So that is one of the key historical as well as examination points that one should take care of while we are seeing such patients. And this is the diagnostic angiogram that shows ostial total occlusion of the left anterior descending artery. Even the RCA is totally occluded, native RCA. The RCA graft is patent, connected to the PDA. And we wanted to see the Lima patency. And the moment we took the diagnostic shot, we realized that we are across the stenosis in the left subclavian. And such lesions are sometimes peculiar to have slow flow, like in this patient. The patient had a slow flow to the LAD, developed a little bit of hypotension, and you can now appreciate the critical stenosis of the left subclavian artery just proximal to the origin of Lima. So this is another peculiar place where both the coronary circulation as well as the vertebral circulation would be affected by this stenosis. And post-angiogram, the patient was complaining of chest pain. He was slightly confused and dysarthric. MRI was done at that point of time that revealed small infarcts in the posterior circulation as well. The ECG slightly from the narrow QRS morphology changed into a wide QRS morphology, and we arranged the hardware in a few hours, and then we went ahead with the intervention. So the culprit was well identified, and this was balloon dilated and subsequently balloon expandable stent 8x29 was deployed across the lesion and stent was inflated, and this is the final result. And the post angioplasty, there is good flow to the vertebral as well as lemma. So this syndrome is very peculiar, known as coronary subclavian steal syndrome. It is analogous to the classical subclavian steal syndrome, but in this, the thief is not just snatching away the blood from the brain circulation, not just from the vertebral circulation. It is also snatching away blood from the coronary circulation, and it has potentially catastrophic consequences. Like in our patient, it needed to be handled, it needed to be prevented, and angiographic assessment of clinical findings like the unequal blood pressure, especially in a post-CABG patients, might go a long way to assess these patients. And we should give importance, like the both cases that we presented today. The clinical examination was extremely important. The case that Dr. Damini presented, that also shows that clinical examination is extremely important. Only the presence of right brachial pulse in that patient was pointing out that even the femorals are not getting adequate blood. So even with the CT angiogram that was documenting the patency of stents, we should be going for an invasive angiogram and documenting what is the cause. And even in this patient, the unequal pulses of the both arm is a very, very strong pointer about the presence of left subclavian stenosis. And assessment prior to our intervention is also important, so that we are cautious about our approach. Thank you.
Thank you, Dr. Tanuj. That was a wonderful case to document vertebral and a coronary ischemia theory, as you called. It's a fantastic case to learn. That's very important. You should not just be looking at the natural or the native arteries, but also should be looking at the collaterals and the flow that exists in the branches and the other vessels, the way the vessel is getting filled up. All right. So any closing comments, Dr. Panja? Dr. Tanuj, any closing comments?
Yes, thank you very much indeed. And the case very excellent and very, very upgrade. It is upgrading our knowledge in day-to-day practice. And I personally thanks to Kamal for conducting the meeting. And I'm very thankful to Kanu Agaral and their team to organize the meeting for upgradation knowledge. All of us as a teacher, as well as all the students. I think more than 500 people, students, were adhered to this to the program. Thank you very much.
Thank you, sir.
Okay.
Thank you, everyone. Good night, and looking forward to have you in other sessions in the next week. Take care, everyone. Bye-bye. Over to Dr. Thank you, Dr. Tanuj. Over to Kanu. Yeah.
Thanks.
Thank you, sir. Once again, this is a very good program. So first of all, I'd like to extend my sincere appreciation to Dr. Damini for presenting a nice case on PVD and handling the question very wisely. And my deep gratitude to Dr. Macleods Pharmaceuticals, sir, Dr. Tanuj Bhatia and Dr. Kamal Sharma for sharing very important insight on this subject. So on this very important occasions, Doctors Day, I would like to convey our heartiest thanks to all the doctors for offering great service for the humanity. I hope remembered for all the human beings for bringing joy and happiness. So with that positive note, on Doctor's Day. I like to salute to all of them, sir, once again on behalf of Macleod. And thanks, Doctor. All my students, please be part actively on this program. I'm sure this all the discussion going to help you in your academic persuasion and exam also. So with that positive note, sir, thanks once again for your patience hearing. Good night.
Thank you, sir.
Good night. Thank you all.
And I request that Dr. Kamal Sharma once again, Manutosh Pan, just wait. Dr. Sir, Abhijit sir is there. Abhijit sir, can you hear me, sir?
Yeah, I can
Abhijit
hear
sir?
you.
Yeah.
Kanu, I can hear you.
Yeah, sir, it's my great pleasure to introduce our Senior Vice President, Sales and Marketing, Mr. Abhijit Ganguly. Kamal Sharma, sir, I think you know, sir, Abhijit sir. Manutosh sir?
Yeah. Hello, sir. Good evening.
Okay, thank you.
Hi. Hi, Mr. Abhijit. How are you?
Yeah, wishing you a very happy
Thank
Doctor's
you, Abhijit.
Day.
Thank you. Thank you. Thank you.
Yes,
Thanks
sir.
to all the fraternity.
And thank you for this valuable session. And really, the contribution, I think I was throughout the session, I was hearing you all. I mean, hats off to doctors really for going into such deep knowledges and really enlightening, and especially the students also. And definitely they would be gaining more addition. The value addition would be much more gaining from you, such senior doctors like you, sir. And thank you once again, sir. And the students wish you all the best. And we'll meet again next time for the next session. Thank you.
Thank you, sir.
Good night,
Okay, thank you
everyone.
all.
Bye-bye.
Thank you, sir.
Bye-bye.
Thank you, Dr. Bhatia, sir.
Bye.
Thank you, sir. Thank you.
Good night, sir.
Okay, namaste.
Thank you. Namaste.
Good night, sir.